Bismillahir Rahmanir Rahim. Our lecture today is sinusitis. Few anatomical points of the sinuses. Maxillary paranasal sinuses including the maxillary sinus, frontal sinus and ethmoidal sinus as well as sphenoidal sinus. The drainage of each sinus is different from one to other. The frontal sinus drain secretion by gravity as well as the ethmoidal, so both of them and the maxillary sinus drain their secretion within the middle meatus. The sphenoid sinus and posterior ethmoidal air cell drain their secretion in the sphenoethmoidal recess in the posterior part of the nasal cavity. The sinuses has an important role in resonance of the sound and humidification of the air passing through nasal cavity to upper part to other part of respiratory tract. What's sinusitis? Sinusitis is an acute inflammation involving one or more of the paranasal sinuses. In children, it's regarded as a complication of upper respiratory tract infection in 5 to 10% of upper respiratory tract infections. Maxillary and ethmoidal sinus are the most common or frequent sinus involved. Acute sinusitis caused by either acute infection of infective rhinitis, swimming and diving, dental extraction and infection, fracturing of the sinuses, including of the sinuses through fracturing of the facial trauma. Paratrauma also can cause sinusitis by edema of the lining mucosa of the sinus and orifice of the sinuses. Predisposing factor: any local cause obstruction in the meatus or obstruction in the nasal cavity or neighboring infection or previous infection in the same sinuses can predispose to repeated acute attack of infection. Any obstruction in the nasal cavity, either by tumor, polyps, septal deviation, or foreign body, can cause acute infection of the sinuses. General predisposing factors including debilitation, elderly, immune deficiency, mucociliary disorder like cystic fibrosis, or atmospheric irrigation or irritation like high fever or change in the weather causing edema of the orifice of the ostia, of the sinus. Bacteriology: usually mixed infection preceded by viral infection. The common is streptococcal pneumonia, Staph aureus, Moraxella catarrhalis, especially children, Klebsiella pneumonia, E. coli, and anaerobic infection in case of dental origin. Pathophysiology of sinusitis: the mucosal lining of the sinuses produce mucus secretion transmitted toward the sinus ostia. This process will be stopped during inflammation of this nasal mucosa because of the edema of the sinuses, leading to edema of the ostia itself and prevent secretion to get out the sinuses. When the bacteria invade the sinus, the pus will accumulate within the sinus and the symptoms start to appear. Postnasal drainage caused obstruction of the nasal passage and an inflamed throat. Acute sinusitis when the respiratory symptoms last longer than 10 days but less than 20 days, while subacute when the symptoms longer than 30 days without improvement. If the symptom lasts more than 120 days, this is regarded as chronic sinusitis. Clinical presentation of acute sinusitis: first of all, its history of upper respiratory tract infection, constitutional symptoms including headache, fatigue, fever, malaise, and nasal difficulty, nasal obstruction, nasal discharge, postnasal drip, halitosis, severe facial pain over the involving sinus, increasing by bending forward or coughing or sneezing, swelling and tenderness over affected sinus, especially in children. Investigation which help us either endoscopic examination or radiological examination. The most important radiological examination is CT scan. It's more perfect in examination of the sinuses. This first picture shows normal maxillary sinus and normal molar and frontal sinus, but hypertrophied inferior and middle tympanoid. So the patient here complaining from nasal obstruction. This insecurity lead to accumulation of secretion within the maxillary sinus and forming air fluid level, as you can see it in the plain X-ray of occipital view in the floor of the bottom of the slide. Another differential diagnosis of any pain in the any disease or some else causing pain or another symptoms of the sinus can be differentiate the acute sinusitis, like dental pain. Here the pain either local on the origin of the dental, or it's can be complaint in the maxillary sinus in case of upper jaw. Migraine can misdiagnose as sinusitis, trigeminal neuralgia, neoplasm of sinuses infection, erysipelas, herpes zoster, temporal arthritis, angioneuritic edema, and insect bite. Treatment: baseline treatment of infection, treatment of pain, decongestant, and irrigation. This is outer line of treatment. Antibiotics according to the age and severity of infection. In simple infection, amoxicillin can be given in 20 to 40 milligram per kg per day in 3 divided dose, and in severe case, augmentin, especially in case of resistance to amoxicillin, so can give in dose of 25 to 45, some 50 milligram per kg in 2 divided doses. Analgesia in form of acetaminophen or brufen, codeine, nasal douching with or irrigation with saline to enhance the passage of secretion from the sinuses, steroid local irrigation spray, non-pharmacological treatment including humidification of the mucous lining of the nasal cavity, and increase oral intake of fluid, saline irrigation of nostril, moist heat over affected site to decrease pain, and prolonged showering to help and promote the drainage of sinuses. Chronic sinusitis. The disposing factor for chronic sinusitis: first, if there is prolonged narrowing on edema of the lining mucosa and narrowing of the ostium of the sinuses in case of vasomotor rhinitis or allergic rhinitis. Smoking and other pollution can irritate the mucosa and make it edema, and nasal polyposis also obstruct the aeration. Endocrine disorder makes edema, cause edema on the lining mucosa, and congenital mucociliary disorder causing stagnation of fluid because of mobile cilia syndrome. Bacteriology usually mixed, either streptococcal, aerobic and anaerobic, negative and positive bacteria. Clinical feature: same as in the case of acute, but for less degree of severeness. Nasal and or nasal drainage of mucoid or periunit discharge, headache, feeling as heaviness or dull ache, and nausea and cacosmia. Sometimes the constitutional symptoms are less. Principle of treatment by decongestant, local and systemic steroid, systemic antibiotics, and surgical drainage. Complication of sinusitis. The complication is orbital complication. How to infection spread in case of clinical sinusitis causing this complication? Either direct through body wall causing osteomyelitis, or venous to the venous sinus, lymphatic, also perineural to central, spread to brain. Types of complication: extracranial, like osteomyelitis. It's rare, usually affect frontal sinus and increase in young adult, causing swelling in the forehead called Buffy tumor. Orbital complications, rare but more in children due to modalities. This is Buffy syndrome, frontal swelling forehead due to frontal sinusitis. Orbital complications of sinusitis can be classified according to severity from cellulitis or the periorbital, orbital, subperiosteal abscess, or called extraorbital abscess, orbital abscess, and cavernous sinus, more serious complication. Other extracranial complications are infection to nasopharynx causing nasopharyngitis, otitis media, pharyngitis, tonsillitis, laryngotracheitis, bronchitis, bronchiectasis, asthma, and arthritis. Intracranial complication including meningitis, extradural or subdural abscess, cavernous sinus thrombosis, brain lesion according to affected sinuses, like frontal bone abscess in case of frontal sinusitis, diffuse suppurative meningitis near cribriform blade through ethmoiditis, diffuse meningitis in case of sphenoid infection, and maxillary sinusitis rarely cause intracranial